My name is Ben Atkinson. I'm the Head of Research Communications and Engagement at Breast Cancer Now, and it is my pleasure to introduce Professor Montserrat Garcia-Closas, who I'm going to refer to as Monsi for the duration of this talk. Monsi is a physician epidemiologist expert in genetic susceptibility and risk prediction for breast cancer. She co-leads the Cancer Epidemiology and Prevention Unit at the Institute of Cancer Research and Imperial College, and is a member and leader of several large international consortia in cancer epidemiology. And related to this discussion is the co-lead of the Breast Cancer Now Generation Study, a study of over 110,000 women specifically focused on finding the causes of breast cancer. And the study is actually celebrating its 20th year anniversary. Monsi, welcome and good evening.
Good evening. Thank you, Ben. A pleasure to be here.
It's a pleasure to have you on. How are you today?
Good. Yeah.
Brilliant. We can jump into some questions. So, Monsi, how did you get into breast cancer research to begin with?
My path to breast cancer research started more with cancer research. So my father lost his battle to cancer when I was in medical school in Barcelona. So when I graduated, I decided to explore the world of research. So I moved to the U.S. initially for 1 year at the Massachusetts General Hospital, and there I really discovered a new area and world of research that I was not aware of. In medical school, I was focusing on how to diagnose and treat diseases. And there, when I was in Boston, I became much more interested in understanding what causes diseases and how to prevent them. So I decided to stay on and did my training in Boston at the Harvard School of Public Health in epidemiology, public health. Then went to the National Cancer Institute in the U.S., and that's where I spent most of my career trying to study the causes of cancer. And I did not initially started my research in breast cancer, but I became very interested during my time at NCI and realized the great potential to improve lives and save lives because of so common cancer in women. So that was my journey to breast cancer.
Yeah. That's amazing, and what a journey. I mean, when we think of research, I think we often think of people working in a lab or testing potential new therapies on individuals, but studies like the Generation Study, they're very different. Can you tell us a little bit more about it?
Yeah, so this study is a study that studies populations, so study populations for a long time. We are, in a sense, getting real world data from individuals as they are progressing through life. So that gives us the opportunity to collect information and biological specimens like blood samples to study determinants of factors that might increase the risk of cancer in the future. And we can capture that because we follow up a large number of participants through time. So this is highly complementary with laboratory studies that are doing research in a much more controlled environment in a laboratory setting. Those are really important to understand mechanisms or to identify targets for treatment. So these two ways of doing research are really highly complementary and give us a fuller picture of the understanding of causes of cancer. So it really is the combination of these population-based studies and laboratory research where we are learning the causes of cancer.
Brilliant. So this research complements directly the lab-based research. Is it that the findings can be translated so we can study the mechanisms in the lab? Is that the idea?
Yeah. Well, it goes both ways. So there could be research that we do in large population studies, like what we call genome-wide association studies, where we scan the genes of the genome of many people, and we're trying to understand what are these changes in genetic changes that are associated with an increased risk of disease, but we don't know why. So then these findings then get taken to a laboratory, and they can understand what are the mechanisms. By understanding the mechanisms, they could potentially lead to developing new drugs for prevention or identifying targets for treatment. And then the other way around, there are some discoveries in laboratories that then that potentially identify a carcinogen, and then we can then go and try to measure this in large studies like the generation study, and then try to see how that works in human populations outside the laboratory setting. So it really goes both ways.
Brilliant. Love that. I can see some questions coming through. I'll get to those in a second. I just want to ask a little bit more about the generation study first. How did you reach 110,000 women and get them to take part? It seems that that's a huge feat.
Yeah, so the study started in 2003, and it recruited women and participants all the way until like 2010, 2011. So I wasn't in the study with them when that happened, but I heard a lot of stories of the colleagues that were there. So it was pretty challenging at the beginning, particularly because they didn't know how many women will actually respond and join the study and in that long-term journey. But there was I think a very partnership with Breakthrough, which is now Breast Cancer Now, to really promote the study and publicize the study through media and different events, even national newspapers, even King Charles at the time, the Prince Charles was supported the study. So there was like a big promotion of the study, so they became famous overnight. And then the problem became from like, I don't know how many people will join to being overwhelmed by the amount of people that had an interest and wanted to join the study. So that took some time to accommodate, but then the study was continued to be very successful, and the study team managed to figure out ways to handle all the volume and the interest from participants. It was really a joint effort with study team, study participants, the funders like Breast Cancer Now, and the support of the Institute of Cancer Research that was hosting the study. So it was quite challenging, but very exciting, and there's a lot of things that were learned through that process.
But it's wonderful that you had so much support from so early on, including the royal family. So a very good start indeed.
Yes.
In terms of discoveries of generation study, I mean, you've just hit your 20 years carrying out the study. What findings are particularly of interest to you so far?
Yeah, so an area that has been that the study has contributed to understand is the area of genetics. So what are the predispositions, the inherited predisposition to breast cancer? And that is one of the areas that I spent a lot of my own research trying to understand. So we've known for a long time that there are rare mutations in genes like BRCA1, BRCA2 that they increase the risk of breast cancer quite substantially, women that carry those mutations. But fortunately, these mutations are quite rare, less than 1% in the population. So what we have learned more recently is that there are many changes throughout the genome that we carry with us, that there are these changes that are smaller increases in risk, but when you put them all together, you can construct what we call these genetic risk scores that can really allow us to identify women at different levels of risk at the population level. And that is not just women with a family history of breast cancer, which is about 10% of the population, but also the other 90% that might not be aware there are a genetic predisposition. And by measuring those genetic changes that we've discovered really in the last 15, 20 years, now we are able to understand better the predisposition to breast cancer and how to identify women that might be at increased risk, could benefit from prevention or early detection, like screening, more frequent screening, for instance.
That's brilliant, because I think I've read somewhere that was over 300 different genetic changes that you were looking at or you've associated with breast cancer. But nothing has come up which is similar to the BRCA gene in terms of increasing risk. Is that right? We haven't found one of those genes again which is specifically associated. It's like a multitude of them.
Yes, there have been also some advances in better understanding the risk of this, like breast cancer, like BRCA1 has many different mutations. So there's been certainly a lot of research that has made more progress in understanding which of these changes are associated with risk, and not just in BRCA1, BRCA2, but in other other genes that are breast cancer genes. So there's definitely been progress there. Those studies require more very large sequencing studies because they're looking at very rare mutations. So I think it's been progress in both sides, but the area that was completely unknown about 20 years ago is more of this common variants that together you can identify, for instance, the 1% of women that have the highest or the worst risk score can have a risk of breast cancer that is maybe 3 to 4 times the risk of an average in the population. So these are pretty high risks that are similar to some of mutations in some of the breast cancer genes.
Okay, that's astonishing. So this kind of risk score, because I know in other conditions there's a various different risk scores just depending on age and genetics and lifestyle. Are you thinking something similar could be developed for breast cancer in particular quite soon?
You mean by bringing together everything that we know? Yes,
Yes.
there's been also a lot of work, and we've used the generation study to evaluate some of these, what we call this combined risk scores, where you are putting together the genetics. Genetics is important, but breast cancer is also it's a very complex disease that's also associated. There are many other factors like reproductive history, alcohol consumption, weight changes. There are multiple factors that if we put them together with the genetic factors, we can better identify women at different levels of risk. So these combined risk scores, they need to be evaluated to see how well we predicting risk, or how well are we at predicting that risk. So the generation study has been very important to be able to do that, because we have a lot of information from participants when they join the study, and then we can see whether we calculate a risk at that point. Then, because we follow people up, we can see whether the predictions that we make, how close they are to reality, of how many people at the different levels of these scores develop cancer. So this information has already resulted in improvements in risk models that are being used in the clinic, like the Bodicea model that was it's been developed in collaboration with colleagues at Cambridge University, and it's recommended by the NICE guidance, as well as the Tyrek-Cuzick model. So there are this research is really fitting into these clinical models that are improving their ability to identify people at risk.
When you say models, to people who aren't familiar with these models that you just explained there, can you explain a little bit more about them?
Yeah, so these are really mathematical models that allow us to put together information about a woman's life, past, and medical history, and family history of cancer, for instance, or their lifestyle factors, as well as measures that we can obtain from a blood sample, for instance, on their genetic. So these are mathematical models that brings everything together, and the output is giving you a probability of developing the disease during a period of time. For instance, whether an average woman in the UK, if you don't know anything about any factors, and you just know that a woman living in the UK, the lifetime risk of developing breast cancer is around 10% or 12%, maybe one in 10 women. But when after you calculate this risk, you can see people that might be at a much higher risk than that, which is the average, or a much lower risk. So that's the number that this mathematical models will give you, so a more refined measure of the risk of developing the disease in the future.
Brilliant. I mean, I can imagine that being incredibly useful for everything that you just said before, in terms of like greater screening and understanding whether someone needs that level of screening or not. Um, Another thing which I think is really important to highlight as well is risk doesn't mean, like, if you have a very high risk, it doesn't mean that you'll definitely get breast cancer. And if you have a very low risk as well, the same is true there. But also, if you have a very low risk, it doesn't mean that you aren't at any risk at all of getting it as well. It's very hard to say that on a population level, isn't it? Because we know the risk is so variable for so many people.
Yes, so these estimations are probabilities, so they can only be calculated in a group of people. So in,
Yes.
say, people like you and these characteristics, that is on average how many will develop the disease. But we can never say a specific individual, specific woman, whether they will develop or not the disease with certainty. It's just it's a probabilistic. It's like the weather prediction, so you can see what's likely to rain or not. But whether rains or not is after you actually see it. So it's really where we have to work with probabilities, which work at a population level, individual level. This can never know.
Yeah, never know yet. But I think this research, there's something why it's so powerful is that the more these probabilities can be developed, we can hopefully at some point have much greater certainty and
Yes.
therefore have better
Yeah.
prevention
So
measures and
as
all
an
those things.
individual, you will know in which group you are. Like if you're in
Yes.
the UK, the likelihood that it will rain is very high. If you're in Spain, it's much lower. So you will know which group you are, but you know exactly that what will happen to a particular person. But you do know a lot of information. You know which group, and different groups might benefit from different prevention or early detection strategies. Better. So that's a very important information.
I can see we had a question from Irene a little bit earlier, and since we're on the topic of genetics, probably great to bring up now. So Irene says, asks, what is your view on BRCA testing on women over 65 with no children or sisters?
Yeah, so that's not sure it's the most qualified person to answer this question, but if usually the current guidance, nice guidance, are of genetic testing follow. They are guided by the family history and the probability of having the mutation. Um, in more recent research, we've learned a lot more about what will be the risk of these mutations when there is no family history at all, and how that changes with age. So this is actually information that was not so well known a few years ago, because most of the information we knew was among women that had a very strong family history. So we don't really know how to interpret those tests for women without a family history and the different age groups. So the information is there, but we have to follow the clinical guidance, and at the moment it's not recommended that it's been tested in that context. But if there's interest in more information, we can definitely provide more resources, and our specialist could give a better answer to this question. It's a very important question.
Brilliant. Thanks, Nancy. You mentioned genetics, or we focused on genetics as a key finding of the generation study. What else has really come out of the generation study that you think people should be aware of?
Yes, so there's been a lot of interest in understanding how our reproductive lives affect breast cancer. So we've known for a long time that women, after having pregnancies or having babies, they have a decreased risk, for instance, of developing breast cancer compared to women that never have children or they're never pregnant. So we knew that for a long time, but research that the generation study contributed have shown that this decreased risk only really happens like at least 10 years after the pregnancy. But there's a period after a recent pregnancy where the risk of breast cancer actually increases. And that increase is mainly through a type of breast cancer that's quite aggressive, triple negative breast cancers. So fortunately, the increase is not very high, and this is still a rare cancer in young women. But that research really help us understand a bit more the complexity of how pregnancies can affect the risk of developing or promoting cancer through the life. So we have this long-term protection, but a short-term increases in risk. So that was some of the research that I think provided more clarity on that. There is other areas like the weight, how weight at different periods in life affect breast cancer. So obesity or weight gain later in life increases breast cancer, but earlier in life, like before menopause, it actually decreases the risk of women that are heavier are actually at lower risk than leaner women to have cancer earlier in life. So these are very complex relationships that data like the generation study has been helping to provide some better understanding of these complex associations.
Yeah, I mean, these findings are complex, aren't they? Because you don't want to necessarily, from a public health point of view, recommend that women necessarily gain weight for a breast cancer protective thing at the risk of actually creating a greater risk of other diseases as well. So there's a fine balance from a public health standpoint, isn't there?
Yeah, no, absolutely. And obesity is one of the most important and challenging public health problems that are associated with many diseases, not just breast cancer. And so these recommendations always have to take into account the trade-offs of different. And there's definitely recommending a healthy weight is absolutely the the recommendation. But this analysis gives us a better understanding of what aspects of increasing weight or decreasing weight, but certainly the most the cancers occurring later in life after menopause are much more common than in younger people, and those are definitely those are increased with increasing weight. So that even if you think only breast cancer, you will never recommend people increasing weight because of that. Yeah.
Yes. What's interesting to me is like you have all these findings, but then I wonder if there's crossover somewhat. So you can almost look at an individual's risk. So if you're able to associate certain genetics with an increased risk, but that means that they're an increased risk of this triple negative breast cancer during pregnancy, then you can better understand an individual risk. And then hopefully in the future, once we have a greater understanding, either prevent or screen for it and catch it early. But is that am I blue sky thinking there, or is that something which could be in the near future?
Yeah, no, definitely. And there's also recommendations you can make. For instance, although there's this small increase in these cancers, what we found is that breastfeeding can actually compensate that small increase. So that really made it even more important to recommend breastfeeding, because that can really compensate this small increase in risk soon after pregnancy for women that are breastfeeding. So it can really translate into emphasizing some of the recommendations and making it even more understanding more the consequences and the benefits of those recommendations.
I mean, yeah. I mean, complex, isn't it? Because I like some people can't do these things and other people can. So I guess it's just meeting an individual where they are and reducing risk where it is possible, right?
Yes.
You are born with the genetics; you can't change those, unfortunately, in some instances. Um, so yeah.
Yes, and a comment on that is that, yeah, although we cannot change our genes, but they don't work in isolation. They work in the context of everything else and our lifestyle, our choices in like taking different like, medications or other things. So you can really modify your genetic risk by modifying other factors that you have more control on.
And there was a really lovely finding that I read on when I was actually writing a report with you recently, looking at exercise and how women exercising in their spare time actually reduced risk in some instances. Can you expand on that a little bit?
Yeah, so this is more recent publication that found. So we know all the benefits of exercise, but what that research showed is that even moderate physical activity in all periods of life, in younger women and older women, have a benefit of reducing breast cancer risk, as well as many other diseases like cardiovascular diseases, diabetes, obesity. So it again was another piece of information that emphasize the importance of physical activity in health.
Brilliant. And then another question, slightly pivoting from this, is that what do you hope researchers will actually be able to do from some of the findings and data that you've gathered from the generation study?
Yeah, so we are trying to. That's actually one of our objectives in the next 5 years is to really try to make the data, the very rich data, the generation study, more securely available to for academic research, not just by the team of researchers at the Institute of Cancer Research and our collaborators, but more for the broader scientific community, because the more minds that are put into the data, the more likely is that we're going to find more discoveries. Of course, this has to be done very carefully because it's always this balance between making the data more available but protecting the privacy of the participants. So we have an objective to try to work on these aspects and really try to make the valuable data available more for research by the scientific community.
Excellent. Brilliant. Just a quick shout out to everyone listening. If you have any more questions for Monty, please do put them in the chat box because we're shortly coming up on time. Monty, there's one more question I want to ask you, because the Generation Study has achieved so much already. What more do you hope to accomplish?
So one area that everybody's excited about is how we can use the advances in artificial intelligence to make progress in research. So an area where looks very promising is analyzing medical images like mammograms from a screening. That even when most of the mammograms are clear, there's cancer that's not found, but there's a lot of information in that image of the breast that could tell us who is more likely to develop cancer, and also we can try to decrease the number of cancers that are diagnosed between screens by understanding who should be screened more often, for instance. So that's an area that we are planning to work on, as well as when there are biopsies, a suspicion of some diseases in the breast that might not be cancer. That tissue again that that biopsy tissue that's collected for diagnostic purposes has also a lot of information. We can use artificial intelligence of those pathological images to also try to understand which women with benign breast diseases or other alterations in the breast might be more likely to develop cancer in the future. We're also expanding the research to try to understand not only what causes cancer, but what are the determinants of prognosis. So after the diagnosis of cancer, so the lifestyle factors, for instance, before and after diagnosis, how do they influence the chances of recurrences, for instance, or survival after the diagnosis? So try to improve also the lives of the many survivors of breast cancer. So these are some of the areas that we are planning to focus on the next years.
Excellent. Fantastic. I mean, yeah, it's unbelievable what you're doing. I'm slightly in awe of the work that you're doing, and I honestly believe this work will have a real impact on breast cancer research, but also breast cancer prevention. So we're coming up on time. I'm just going to quickly check whether we've got any more questions in the chat box. We don't. Monty, before we close, do you have anything else you would like to share?
No, it's been a pleasure talking to you. So hopefully that was useful for people in the audience. And if there are more questions, I know you have helplines and a lot of resources that people can reach out after this.
Absolutely right. So, Monty, it has been a real pleasure speaking with you this evening. I hope that you thoroughly enjoyed it. Sounds like you did. Thank you, everyone, for tuning in. I hope you found this information interesting. So, Monty, thanks so much for coming on the show, and I hope that we can do this again soon.
Thank you. My pleasure.